is, according to the American Society of Clinical Hypnosis, is a wakeful state of focused attention. Wakeful. But you can also use hypnosis to put somebody into a not really wakeful any longer state. But then you can't use it for medical purposes very nicely because they don't remember, which is very bad, you know. Patients don't like not remembering things, so we don't do it. Hypnosis is usually preceded by an induction. So you create something where you walk into this state of mind. Hypnosis is administered by somebody, for instance, a physician or a psychologist, and also can be administered by somebody to himself. We have got the notion that if I administer hypnosis to you, that you take it and administer it to yourself. So I cannot access you without you filtering the information. So every hypnosis is in a way also a self-hypnosis. Hypnotherapy is medical hypnosis or is therapeutic hypnosis. In the medical setting, you always have a setting, which is a certain room or a place or whatever. You've got a certain process consisting of different parts, and you have a feedback system established. This can be verbal or non-verbal. Some people like to wiggle with their fingers. I prefer to talk to the patients. It's a little bit more difficult to talk if you're in hypnosis than if you're just awake, but it's nicely possible. The state is a relaxed but concentrated state. How can that be? How can you be relaxed and focused and concentrated at the same time? Well, think of a room that is dark. If you want to see something, then you can either make it bright, or the room, or you can use a torch and focus the light of the torch to a certain person or a certain aspect. And that's what hypnosis is like. You don't have a room that is light, but you've got, or which would be a metaphor for being awake or being active, but you've got something which is very quiet, and you still focus on a certain aspect. Everything is dark, but your focus of attention is bright. And you can still very nicely see this aspect. That's hypnosis. Medical applications are different, of different kind. Pain is my speciality in hypnosis. Using hypnosis is headache. But perioperative measures are very, very prominent also in the literature. About half the literature focuses on perioperative or peri-procedural measures, or using hypnosis around something that a doctor does to their patient. Willpower does not have to do anything with hypnotizability. It is not the case that somebody says, well, I'm a strong person, you know, I've got a strong willpower, you cannot hypnotize me. That's not true. If somebody with or without willpower, whatsoever this concept, I don't know, what is willpower anyway, psychologically? Can you explain it? You're the psychologist, you know, I'm just a doctor. I don't know anything about psychological concepts. What is willpower?
It's a lay concept, actually.
It's a lay concept. I suspected that it's a lay concept. But people come to my practice and say, well, it depends on willpower. It does not depend at all on this lay concept, but it depends on various things that we are not quite clear about. But there is a phenomenon that we call hypnotizability, which probably consists of a variety of aspects and can be measured and also is measured in the literature. We have in Switzerland the SMSH, Société Médicale Suisse d'Hypnose, die Schweizerische Ärztegesellschaft für Hypnose oder Swiss Society for Medical Hypnosis. It's a society of more than 500 persons, doctors, physicians, and we basically have in common that we work using medical hypnosis. Claudia gave me the task of talking about evidence and clinical implications. What is evidence at all? Is it RCTs? Is it meta-analysis? Is it systematic reviews? Well, of course it is, but in hypnosis we have another kind of problem, you know. With MBSR, nobody doubts that meditation exists. Everybody says, okay, meditation does exist. It's not the same with hypnosis. With hypnosis, that's really the question, does it exist at all? And if we look at evidence, well, we have this, this classic publication by Sackett, who is one of the fathers of evidence-based medicine. We've got the individual clinical expertise, we've got patients' values and expectations, we have best external evidence, that's of course RCTs, meta-analysis, systematic reviews. But with hypnosis, we've got this tradition as well. You know? That's something that is, for instance, forbidden in Sweden. Show hypnosis, if you do show hypnosis in Sweden and you're caught, then it can well be the case that you go to jail. Mowgli, well, he's clearly hypnotized. You know, he's the patient. Here, you see that? Here it's just the same. Does it exist at all, and can it be used for medical purposes? And of course, the psychiatrists and the neurologists, they thought that they have the major contribution to answer the question about, well, in this context, but in fact, it is not the psychiatrists who do the most complex hypnosis, or the neurologists who deal with the brain, but the anesthesiologists who made a major contribution to better understanding hypnosis and medical hypnosis. And of course, well, Tim, you were not surprised, neuroimaging was playing a major role here. What did the anesthesiologists do? Marie-Elisabeth Marie-Lise Feymonville, she was a young anesthesiologist at the University of Liège, and the department of plastic surgery was given to her as an anesthesiologist. So she had to coordinate and lead all the anesthesiologists who do the narcosis for all those patients who undergo those operations, elective operations, to improve their beauty, things like that. And Marie-Lise Feymonville, she thought, well, that's a bit of a problem, because they get narcosis, and narcosis are also can be called artificial coma. And if you use as a doctor, if you use an artificial coma, you might introduce some brain damage, especially in elderly people. And if you do that as a doctor, you might have some ethical problems, and she did actually have some ethical problems with the context she was working in. So she decided to learn hypnosis, in fact, and to try to avoid operations and develop this technique, and that is called hypnosedation. And what she does is she replaces the general anesthesia by hypnosis and a local anesthesia. So it's like you're at the dentist, you get a local anesthesia, and she hypnotizes you, right? But the operation is not extracting the tooth, but the operation is enlarging a breast or diminishing the size of a breast. And I went up to Liège and had a look into this, watched several of these operations, or facelift. Facelift takes about 6 hours, and it's an operation that is actually quite painful. And she really does the same procedure as when you go to the dentist. She hypnotizes people, and I was watching a lady where I could see the pectoralis and I could see the ribs basically exposed, and it was possible to talk to her. So it's a kind of almost scary situation, because if you imagine what happens if you clap your hands, she gets out of hypnosis. I wasn't very comfortable standing there and behaved very, very quietly when I talked to this lady, but it was possible to talk to her. So obviously enough, according to which mechanism, well, several mechanisms, I don't know, but it seems to work. If you can cut into people under hypnosis, it seems to be the case that something happens with your brain. They did about 7,000 operations at the University of Liège, and by now it has spread into the French-speaking part of Europe, into France, also into Western Switzerland, and about 200 anesthesiologists have learned this technique. Of course, it takes a long time, etc. Something which is interesting for me and for you is that the result of this was a research program, because it's a short intervention. She saw patients once before this operation. They did a test hypnosis. If it worked, they were admitted to hospital. Of course, there was a selection bias, because only people who thought they can do it went up to her. Others who didn't like the technique, of course, didn't volunteer to do these operations under hypnosis. So there certainly is a strong selection bias, but still about 90% of the people who she had one session with were admitted to the operation. So that's clinical evidence that something happens there. It's a technique that changes something, so you can cut knives into people. And it's a simple technique, it's highly standardized, and therefore it's nice for research. Everything that is simple and highly standardized is nice for research. So you have possibly a strong signal and very little noise or variability. And in an early work, what they found, this is PET, and Tim, thanks for introducing all the imaging techniques, so I don't have to explain much. PET examines metabolism, basically, and what Pierre Maquet, who is a prominent narcolepsy researcher and neurologist and sleep researcher at the Université de Liège, they found that in hypnosis, compared to the control state, which Marie-Lise Feynman calls autobiographic memory, where people have the same, if you go into hypnosis, you do the induction, etc., you deepen the state, and then you go back to your last holidays, a nice beach, Waikiki beach, I don't know, whatever, or Italy, maybe, then you use as a control state, you use the same type of beach, just without the induction, without the deepening of the trance, etc. And they found differences with more frontal activation using hypnosis and a more pronounced right hemispheric activation. And this might coincide with the observation that people under hypnosis, they have less impulses, but also less control, which might be attributed to an altered frontal lobe function. And also thinking or being in hypnosis can be a very somatosensory, three-dimensional experience. So if you go in hypnosis and you think that you go skiing, then you really feel the slope, etc., and feel the velocity and the change of direction. For the study, for the data I'm showing you now, this very old, basically very old concept of the classic pain neurometric that you also mentioned in your talk briefly was used with a distinction or a differentiation between the intensity of the pain sensation and the so-called unpleasantness. And according to this crude model, and not, well, in reality is far more complex, simplified model, there is a lateral part of pain perception, a sensory discriminative part, and a medial part, a motivational affective part, and the lateral part of the pain neurometrics, as they call it in the older literature, is responsible for the sensation and also the intensity, the numerical intensity. You usually ask to gauge pain intensity 0 to 10 or something like that. And the medial part is connected to the so-called unpleasantness. And where in older papers before Feymonville this could be dissociated, she did find an effect of the hypnotic state on both aspects, but both of them were basically influenced similarly. And I think one could try to compare the MBSR results to these hypnosis results and see what the difference might be. Anyway, pain also, the representation of pain and the ratings of pain seem to be strongly influenced by the technique of hypnosis. And here you see one part of the cingulate cortex that is thought to play an important role in pain perception. In this medial part, the mid-cingulum, that is, in this study, Feymonville 2006, highly correlated with a pain perception rating in the hypnotic state, but not in resting state, and also not in this controlled state of mental imagery. Furthermore, well, I progress here. That's too much detail. So the Liège experience was that it is clinically possible to perform operations replacing general anesthesia using local anesthesia, similarly to the dentists, combined with hypnosis. And there seems to be a brain state, at least that's what the Liégeois say or tell us, that is rather specific for hypnosis, and that's different from the control condition of mental imagery. I'm not sure whether in 50 years we still will be thinking the same thing, but that's what they state at the moment. And we can discuss it later also, what the difference and what the similarities might be between the different types of meditation or techniques to alter mental state. Both intensity and unpleasantness are modulated during hypnosis. And it seems to be the case that the mid-cingulate cortex plays a critical role in hypnosis-related alteration of sensory, affective, cognitive, and behavioral aspects of nociception. I didn't go into that detail here because of the lack of time, basically. Clinical data. Looking at clinical data, I want to predominantly focus on a huge meta-analysis that, of course, because it's so large and it has such a long time span, must be flawed by methodological problems, and I'll show you why. It includes studies from 1889. I don't know what study methodology, well, Claudia, you're a methodologist, a well-known study methodologist. What about study methodology in 1889? How much was there? And how difficult must it be to include such a study in a meta-analysis? Well, it's...
Second part is the most important one, but there have been randomized trials in the 19th century, but not on hypnosis, on other things.
In other things. Anyway, the signal that comes from this meta-analysis is actually compatible with the signals coming from newer meta-analysis. And still, I would like to show you this one in some detail. 188 controlled trials, more than 10,000 patients, all studies about the efficacy of hypnotherapy. What's the distribution of the studies? About 91 studies, about 50% of the studies deal, and about 50% of the patients deal with hypnosis as an accompanying measure for operations or medical procedures. Psychosomatic disorders of different kinds, 68 studies, about 3,000 patients. Anxiety disorders, 14 studies, about 600 patients. About half the studies were pre-post comparisons. So they looked at patients before the intervention and after, and compared them before and after intervention. About half the patients, 5,000 patients. And about half the studies used some sort of control group. Either some other method, waiting lists, treatment as usual, which is a crude distinction. And it is, of course, as you see this distinction, well, methodology is certainly a problem here. The observation period had a mean of 8 weeks in these studies that's spread over more than a century. And the duration of therapy was 1 to 60 sessions. Interestingly enough, the mean number of sessions was 5. That's not a lot. If you look at MBSR, where you have 8 weeks, you have homework 45 minutes per day for 8 weeks, the number of 5 sessions is a small number. It seems to be the case that a relatively large effect size can be reached within a relatively short period of time using this type of method. This is compatible with the clinical information from the anesthesiologists. They do 1 test session and then they operate. So it seems to be the case that somehow this method is rather quick. Whether it changes the brain within this time, probably not. But clinically it seems to work. If we look at the pre-post design, of course, as we would expect, the effect size seems to be larger than the control group. But still both numbers are relatively high, maybe due to methodological problems. Interestingly enough, and that's another signal that comes from this relatively large meta-analysis, the effect size seems to be stable or to even increase after the end of the therapy. Well, is that intuitive? If you learn something, if you learn a skill and you use it all the time, and you continue using it after the medical or psychological intervention, well, it might be intuitive. I'm sure that those people who learn MBSR and finish after 2 weeks, but continue their practice by themselves, without you being there all the time, that the effect size also increases over time. So it might be actually intuitive. And you see here that this is both true for the pre-post design and also the control group. If you look at medical or surgical interventions and psychosomatic problems, anxiety and smoking cessation, then especially in smoking cessation here and anxiety, the same is true. The effect size increases over time, seems to increase over time. So there is evidence for medical hypnosis as an accompanying measure for operations, to treat psychosomatic disorders and chronic pain, and to treat anxiety disorders, smoking, and eating disorders. The duration of the therapy is relatively short, average of 5 sessions, but also, in most cases, at least stable, sustained, or even increasing over time. Now, let's, as we have looked at this relatively large time span, and as the perioperative procedures are very important, I would like to focus on these looking at this meta-analysis from 2013 from Tefikov et al. That was a literature search, and only 34 very well-conducted RCTs were selected with a total of 2,600 patients. A random effects meta-analysis was performed and showed positive effects on those aspects: emotional distress, pain, medication consumption during the perioperative procedure, physiological parameters, recovery, and the surgical procedure time. And you see here that the kind of soft factors were influenced stronger than, for instance, physiological parameters, which is something that I would also consider to be rather intuitive. There was clearly a benefit of hypnosis on various aspects of these peri-interventional parameters, and the soft factors were influenced stronger than the harder factors. Again, interestingly enough, if they looked also at the complexity and at the length of the intervention, and the authors found that the length of the intervention was not at all correlated to the success. So it seems to be the case that using hypnosis as a tool, as a clinical tool, that it is not really necessary to do it in a complex or a prolonged way, that short interventions seem to be sufficient to obtain clinical results. But, of course, this was a more methodologically stringent analysis, and also looking at hypnosis, randomized controlled trials are difficult to perform by themselves because control conditions are difficult to perform. People know whether they are hypnotized or not. People don't really like the idea of randomization very much in this context, etc., etc. And again, similarly to MBSR, methodologically stringent studies need to be done, and possibly we also need to advance study designs and control conditions in order to better investigate these phenomena. I think it's something completely different administering a pill that is coated without any active ingredient and another pill that looks similar with an active ingredient, and to compare the two, than a complex behavioral procedure where people basically know whether they are in the control group or in the active group, and which cannot effectively be blinded. So study or trial design is an important task. To summarize, hypnosis is a wakeful state of focused attention, and it is also a relaxed wakeful state of focused attention. There is neuroimaging evidence suggesting the existence of a possibly specific or rather specific hypnotic state. Medical hypnosis uses this state for therapeutic purposes, and there is evidence for medical hypnosis as an accompanying measure for operations. About 50% of the literature deals with this, and that's probably also for methodological reasons. It's easier to study these contexts compared to prolonged psychotherapeutic interventions. But it's also effective to treat psychosomatic disorders and also chronic pain, and I'm using chronic pain in the neurological context, and with a focus on chronic headaches, mainly. That's my practice. It's also effective to treat anxiety disorders, cessation of smoking and eating disorders. The duration of the therapy is relatively fast, an average of 5 sessions, and also seems to be sustained or can even increase. The length of the intervention is not well correlated with success, and there is a trend towards increasing usage of medical hypnosis, similarly to MBSR, or at least, well, trend towards increasing usage, we don't really know, but a trend towards increasing studies on medical hypnosis. And what's the clinical implications? Based on this imaging data, I think it's fair to assume that hypnosis does not only exist in the show context, but is a real phenomenon. So you, who are sitting here, you can use hypnosis for medical purposes. I can tell you, being involved in the society, it is something that everybody is able to learn. Doctors, psychologists, other health professionals. It seems reasonable, of course, based on this evidence that I showed you, and also the other evidence that is similar to the one I showed you that I didn't refer to. It is reasonable to predominantly use hypnosis where the evidence suggests good efficacy. Logical. As an accompanying measure for operations or also medical procedures. In the neurology context, we use it, for instance, for the fibroendoscopic evaluation of swallowing, where we put a tube through the nose and look at swallowing. This is very unpleasant. It's like sticking a pen into your nose. Well, there are nicer things to do, and it's better if you're hypnotized during this time compared to you're not hypnotized during this time, or you're relaxed during this time. It makes it easier to go through it. It is also possible or there is evidence to treat psychosomatic disorders and chronic pain and anxiety disorders, smoking and eating disorders. As the duration of the therapy is relatively fast, and complexity is not correlated with success, in contrast to maybe other techniques, keep it simple and start soon within your usual medical frame of reference. With start soon, I mean if you decide to learn medical hypnosis, to learn the technique of medical hypnosis, and you stay within your usual medical practice, that is something that in the society we always do, then it's reasonable to start soon to get experience and practice. What does it mean we stay in the usual medical reference? As a neurologist, I would not try to treat anxiety disorders. As a dentist, they should not really treat chronic headaches. As a general practitioner, they should not try to extract teeth using hypnosis. Everybody stays within the professional society. Everybody uses hypnosis within the framework of their usual work as an additional tool. And under these circumstances, it's quite possible to learn it and start the next day. There's a trend towards increasing usage of medical hypnosis and increasing research. So if you use hypnosis, you're in line with this trend. Thanks a lot.